Good afternoon, everyone, and welcome to our Thursday afternoon webinar. I'm Melinda Bikini, Director of Patient Services with the Cholangiocarcinoma Foundation, and I'm also a 13-year survivor of cholangiocarcinoma. Today, we are happy to be joined by Dr. Thomas Schuetz, who is the co-founder of Compass Therapeutics. He has over 20 years of experience in oncology, biopharmaceutical drug development, and life science venture investing. Thomas completed his medical training at Massachusetts General Hospital, where he served as the chief medical resident, and he completed a medical oncology fellowship at the Dana-Farber Cancer Institute. Thomas holds a BS in chemistry from Xavier University and an MD from Harvard Medical School and a PhD in genetics from Harvard University. I will invite everyone to put their questions in the Q&A box or the chat box at the end, and after Thomas is done presenting, we will go to those questions and answers. And as a reminder, please keep your questions general and don't ask personal medical advice, as he won't be able to give that to you on this forum. And thank you for joining us, Thomas, and I will turn it over to you.
Thanks so much, Melinda, and thanks to the Cholangiocarcinoma Foundation, of course, for inviting me to talk to you today about our drug CTX-009 that we're very excited about. It's super nice to be back with you all again. I talked to you all last year where I gave an introduction to this drug and some preliminary data. At the time that I talked to you last year, we were right in the middle of submitting a study to the FDA. And I'm happy to report to you that today this study is ongoing. And I'm going to summarize that today and review some of the data around the drug as well. Okay. All right, just very briefly, of course, CTX-009 is an investigational drug. So it's a drug that's not yet approved, and we're currently investigating this drug in clinical trials in the United States. So just very briefly, because I know we talked about some of these things last time, and I know that you all are very familiar with the different types of treatments that are used to help patients with cancer. So chemotherapy, which everybody's familiar with, are generally chemicals that kill cancer cells. And an example of that, of course, is gemcitabine that I know most of you are very familiar with. Biologics therapy are a little bit different. You know, these are therapies that are made in living cells. They're generally proteins. And an example would be monoclonal antibodies. And an example that many of you might be familiar with is Herceptin, because some folks with cholangiocarcinoma have tumors that are HER2 positive. Immunotherapy is a type of therapy that stimulates your immune system. And last year, there was a fairly big advance that showed that the drug Imfinzi is helpful for patients with cholangiocarcinoma when it is combined with chemotherapy. And then finally, targeted therapies, which I know many of you are familiar with, are drugs that target a specific mutation in the tumor. So for folks with cholangiocarcinoma, for example, some tumors have mutations in a gene called FGFR2, and Pemazyre is an example of a drug that would be considered a targeted therapy. Drug development, as you know, takes quite some time. You know, there are multiple different phases, phase 1, phase 2, and phase 3. So with CTX-009, we're toward the right-hand side of this today, I'm happy to report. So we've finished our phase 2 study, and I'll summarize that briefly today and talk about our phase 2/3 study that we've started in the United States, and I'll give a little update on that toward the second part of the talk. So let's talk a little bit about CTX-009 and talk about how we discovered that this drug could benefit patients with cholangiocarcinoma. So CTX-009 is something called a bispecific antibody. So what that means is, first of all, it's a biologic, so it's made in living cells and it's a protein. Now, it's a bispecific antibody, and what that means is that it can bind two different targets at the same time. A little cartoon of 009 is over here on the right. So it binds to two different targets. One is called VEGF-A. VEGF stands for vascular endothelial growth factor, and DLL4, which stands for delta-like ligand 4. Both of those targets are involved in generating a blood supply to the tumor. And that is called angiogenesis. That is the generation of blood vessels within the tumor, which is the way that tumors feed themselves. And CTX-009 probably disrupts the way that blood vessels are formed within tumors. So CTX-009, again, by blocking two targets that are involved in the way that blood vessels enter into tumors, we can, if you will, kind of starve the tumor, okay? So by affecting the way that the blood supply goes into a tumor, we feel that if we cut off the blood supply to the tumor, that that could have a meaningful effect on the tumor. And angiogenesis has been targeted with drugs like Avastin. Avastin, which some of you know, has been studied in patients with cholangiocarcinoma. It's also an important drug for the treatment of patients with colorectal cancer, for example. So targeting the way that blood vessels form in tumors has been an important part of oncology therapy for probably about 20 years or so. So let's talk about some of the data that we have seen with our drug. So we've done two studies that were phase 1 studies, and we've recently completed a phase 2 study in patients with cholangiocarcinoma. So this drug was discovered in South Korea, and the initial testing of this drug was done in South Korea. Interestingly, in our phase 1 study, which is generally designed only to look at safety, we saw some tumor declines in patients with colorectal cancer and gastric cancer. Then we did something called a phase 1b study, where we studied CTX-009 in combination with chemotherapy. And in that study, we saw something quite surprising, which is we saw a couple of patients with cholangiocarcinoma who had substantial declines in the size of their tumors while they were on study. And that observation led us to design a phase 2 study, and I'll summarize that in a minute. So in the phase 1b study, we had patients with all kinds of different tumors that were enrolled. Probably 6 or 7 different tumors were enrolled. And we saw tumor declines in several patients in that study. So this slide is something called a waterfall plot. So what this is each bar represents the tumor of an individual patient in the study. I have these bars color-coded by the type of tumor that the patients had. So over here on the top right, you can see gastric cancer, a type of stomach cancer. CRC stands for colorectal cancer. Cholangiocarcinoma is in the orange color, pancreas cancer in blue. So all of these waterfall plots have percentages over here on the y-axis. So in the middle of the chart here is 0. So anything above the line means that while the patient was on study, their tumor got a little bit bigger. So unfortunately for those 4 folks, the study drug didn't shrink their tumor. But over here on the right, for about 2/3 of the patients in the study, you can see negative numbers here. Their tumors declined substantially on the study, and 4 patients crossed a threshold of 30%, which we use commonly in clinical studies to define a response. And fascinatingly, in the orange color over here on the right, the 2 patients that did the best out of all the patients in the study were 2 patients with cholangiocarcinoma. One of those patients actually had nearly a 2/3 decline in the size of their tumor. And both of these patients who had received chemotherapy previously, both of these patients were actually on study for more than a year, a really interesting finding for us. And this simple observation informed the design of our phase 2 study, which I'll come to in 1 minute. So here are some CT scans of one of the patients in the study with cholangiocarcinoma. I'm sure many of you have seen your own CT scans. So this patient over here on the top row, so in the liver, in the red arrow here that I'm highlighting here, is a large cholangiocarcinoma in the patient's liver. Unfortunately for this patient, the disease had spread outside of the liver. Here on the bottom row, there's a tumor in the lung. And over here, there's a tumor that had gone just below the patient's skin in their pelvis. So moving left to right is time. So you can see a large decline in the patient's tumor in the liver that continued to decline over time. The metastasis, the tumor that was beneath the patient's skin, actually completely disappeared in this patient. And the tumor that had spread to the lung had almost entirely disappeared. And overall, as I mentioned on the last slide, this patient had about just under a 62% decline in the size of their tumor, which in the early development of drugs in oncology is thought to be a really good signal that the drug might have some activity in patients with this disease. Of course, all drugs have side effects, and it's just important to talk about those. So when 009 is given by itself as a monotherapy, the most common adverse event that we saw in patients was high blood pressure or hypertension. So that is something that is quite commonly seen with drugs that target angiogenesis, and that has been very well described. And there are now published algorithms for treating the hypertension associated with angiogenesis inhibitors. And if patients in our study have elevated blood pressure, they're then treated with drugs that are called antihypertensives, of course, and those drugs are generally effective for treating that hypertension. When combined with chemotherapy, of course, we see other things, nausea, fatigue, cells in the blood that decrease, some diarrhea, anorexia, which is the feeling of not wanting to eat, of course, which I know, unfortunately, many of you are familiar with the side effects of chemotherapy. So based on what we saw in that study, we designed a phase 2 study. And this is a study of all patients, but only with biliary tract cancers. So cholangiocarcinoma plus gallbladder cancer, etc. So patients get our drug, CTX-009, which is given intravenously every other week. That's given with the chemotherapy drug paclitaxel, also known as Taxol, and those patients are given Taxol once a week for 3 weeks out of 4. So the phase 2 study that we did is something called a Simon two-stage study. And what that means is there are 2 stages to the study. So in stage 1, we treat a small number of patients, so 21. And if we saw 3 declines in patients' tumor, we would then treat an additional 45 patients. And this is something called an adaptive phase 2 study. I'm going to come back to this slide in 1 minute. So earlier this year in January, we presented updated data from this study at a scientific meeting called ASCO GI. And here are the patients enrolled in the study. So 24 total patients, so around 60 years old on average, approximately. A little bit more men than women over here on the top right. So approximately half the patients had chemotherapy once before. About half the patients had chemotherapy twice before. So this is a mix of patients with 1 or 2 prior therapies. So almost everybody had received gemcitabine plus cisplatin, which I'm sure many of you are very familiar with. That's the most common chemotherapy set of drugs that are given to patients when cholangiocarcinoma is newly diagnosed. So we had over here on the right, we had patients with all different types of biliary tract cancer, cholangiocarcinoma within the liver or outside the liver, about half the patients, 12 total. We had patients with gallbladder cancer and patients with ampullary cancer, which is a little less common subtype of biliary tract cancer. So remember a couple of slides ago, I showed you the waterfall plot from our phase 1b study. So here's the waterfall plot from our phase 2 study. So first of all, there's nobody above the line. So every patient that we treated in this study had some decline in their tumor burden as measured on their CT scans. Of the 24 patients that were enrolled in the study, 9 patients had a decline of 30% or more. So that gives us a response rate, 9 divided by 24, of 37.5%. As some of you may know, unfortunately, once gemcitabine plus cisplatin with or without Imfinzi, once that chemotherapy regimen no longer is working for the patients, chemotherapies after that usually have extremely low response rates, something like 5 to 10%. So this is something very, very encouraging to us. So color-coded here are the subtypes of cholangiocarcinoma. So we had 1 partial response in at least 1 partial response in each of the 4 anatomic subtypes of biliary tract cancer. And you can see a whole set of patients here with declines that did not quite reach the PR partial response cutoff. This one patient here had a 33% decline that was slightly lower on the next scan. So that patient doesn't count as an official response, but we had 10 total responses. So I'm just going to go back 2 slides, if you don't mind, and just talk about what we decided to do here. And after some interactions with the FDA in the United States, the FDA encouraged us not to do stage 2 of the study. And they encouraged us to do a randomized study, which could potentially lead to the approval of the drug in the United States. And that's what we have decided. So we're not going to be moving forward with stage 2. Instead, we started a new study, which I'm going to talk about in 1 minute. So interestingly, patients were on drug for quite some time. The median time over which patients' tumors did not grow was over 9 months. And patients on average, lived over a year on this study, which, we hope to do better, of course, ultimately. But once patients have received chemotherapy before, other chemotherapies that are used don't have results that are anywhere close to this. Obviously, this is not a comparison study, so I can't really, compare these results to studies that were done independently of this, which is why we're now doing a randomized trial. And over here on the top right, I think is something potentially important. So the patients who had only one prior chemotherapy treatment, those patients did quite a bit better than patients who had two. In fact, among the patients who had only one prior chemotherapy regimen, 7 of those 11 patients had a partial response for a really, really important number here of almost a 64% overall response rate in those patients. So here are the survival curves. Progression-free survival here over on the right, 9.4 months. Overall survival here, 12.5 months that you can see on this slide. So again, it's important to talk about the side effects of the drug and the combination of 009 with Taxol. So decreases in blood counts, white cells, red cells, and platelets, and hypertension, again, are the most common. Unfortunately, I'm sorry to tell you that we did have one patient who unfortunately died on the study. That patient had pneumonia, and unfortunately, that patient died on the study. Over here on the right, I'm comparing what you would expect to see with Taxol, where we see quite similar levels of blood count decreases, and Avastin, we see almost identical levels of hypertension with 009 that you see with Avastin. So here's where we are today. 10 partial responses, 9 of which were confirmed, for a 37.5% overall response rate in patients, again, who were treated after 1 or 2 prior therapies. 64% response rate in patients who had 1 prior therapy. And as I know you all know, I mentioned earlier the 3-drug combination FOLFOX, only a 5% overall response rate. Even gemcitabine plus cisplatin plus Imfinzi, that has a 26.7% response rate in patients who are being treated for the first time. So we feel really good about the signal that we have coming out of our phase 2 program. And that signal has led us to design a study that is now enrolling. So the last time I talked to you all, we were just in the middle of our submitting this study to the FDA in the United States, but this study is now open and is enrolling patients. So this is a randomized trial, and I'll talk more about that on the next slide, of CTX-009 with paclitaxel versus paclitaxel alone. Here's the clinicaltrials.gov reference number for the study. And all of the sites that are open are listed on our clinicaltrials.gov webpage, and we're continuing to open sites over the coming couple of months. So this is an important slide that I want to spend a minute going over with all of you. So this is something called the study schema. So we're planning to enroll 150 patients. So this is something called a 2-to-1 randomization. So it's not a coin flip. The randomization is skewed toward the treatment arm of 009 with Taxol. So 100 versus 50. So interestingly, I think obviously, this is, perhaps not so attractive to patients, and we're certainly aware of that. So we're allowing crossover in this study. So if patients are randomized to the paclitaxel arm, and if their tumor gets bigger, patients are then given the option to cross over, quote unquote. That is, if you're randomized to paclitaxel and your tumor gets better, you can switch over to 009 with paclitaxel and get that if you are randomized to the paclitaxel arm. So we feel, that this is the best way. Ultimately, in order to get the drug approved, we have to do a randomized trial in some way, shape, or form. But we believe that this study, is the best of both worlds, that we can potentially use this study to get the drug approved in the United States. But we're also, cognizant of the fact that if a patient is randomized to paclitaxel and their tumor gets bigger, we want to offer those patients the crossover to 009 with paclitaxel. So this is the study design that we're running. So currently we're open at maybe just under 20 sites in the United States, which are listed here. We're also working with several additional sites, and I think over the coming month or two, we're probably going to add a large number of additional sites. You can see California obviously is excluded for the moment, working with several sites in California. We're also working with some sites in the northern Midwest, and we're also working with some potential sites in the southeastern portion of the US, thinking about, just broadening, how geographically dispersed throughout the United States this study is. So stay tuned, over the coming month or two, we're going to, increase the number of sites and expand this geographically throughout the United States. So again, I really appreciate the opportunity to talk to you all today. I'm happy to take questions if folks have any questions. So thank you very much.
We did have a few questions come in, and I will get to this, but I'm just wondering, Dr. Schuetz, if you could maybe go over some of the primary inclusion/exclusion criteria that might be relevant to our patients.
Sure. So the most important one is patients have received one prior therapy. So that's the most important inclusion/exclusion criteria. So, and usually today in the United States, patients are getting gemcitabine, cisplatin, and Imfinzi, or gemcitabine, cisplatin plus Keytruda. So one regimen, and then you can go into the study. So this is a quote unquote second line study. So that's the most important one.
At least one, can they have more than one?
So they cannot have more than one.
Okay, so only one prior.
Only one.
Okay.
Correct.
Perfect. All right, let me see. If a patient had a liver transplant, can they still join the study? Transplant was over 10 years ago.
Yes.
Okay. Is this effective in existing established blood supply versus only new angiogenesis?
That is a very complicated question. So we don't know the answer for sure, but it is probably effective for both. So it's probably effective for both, but we don't for sure know that yet. we're doing some work in our research laboratories here at Compass to try to answer that question. But that's a fabulous question.
Okay. Is there any differentiation of using an initial chemo that was stopped due to the potential side effects, cisplatin and renal precautions after 8 cycles? It was working, but had to be stopped.
I think that that would be okay. I think that would be okay.
Okay. Okay, I think this went back to one of your first slides when you were describing the different treatments. Given Herceptin targets HER2 overexpression, is it not also a targeted therapy?
Sure. That's a great question. So it probably could be considered a targeted therapy, but as the field has evolved, and we've discovered more and more genetic mutations, targeted therapy now is commonly used to describe drugs that treat tumors that have specific mutations. Part of the reason that we're so excited about CTX-009 is you don't have to have a specific mutation to get this drug. So this is something that could treat a much broader segment of the patient population, because you don't have to have a specific mutation in your tumor. And that's part of the reason we're so excited about it.
Sure. Are there any characteristics that would suggest a cholangiocarcinoma patient may not respond to CX-009?
We have not discovered that yet, but we're early in our development of the drug, and that's a very important question, the way you phrase that, because it's equally as important to figure out if the drug might not work for somebody. So that's something that we're still working on.
Okay. Is a patient eligible for this study if they've undergone chemo and targeted proton radiation?
Yes.
Will or could this drug be tested in combo with Gem/Cis for cholangiocarcinoma?
So yes and yes. So that is an incredibly exciting question for us. We're working currently with a major academic medical center to put together a study that looks at 009 in combination with gemcitabine and cisplatin. So that's probably not this year, but that's something we're super excited about.
Great. I think I know the answer to this, but would I be excluded if I started on Gem/Cis and switched to FOLFOX oxaliplatin with multiple cycles of each? Also have had Y90.
So unfortunately, I'm sorry, no. So if you got FOLFOX, you would not be eligible. I'm sorry. Okay.
Can you speculate on the reason for difference between intra and extrahepatic response?
So we're learning more about the differences between intrahepatic cholangiocarcinomas and extrahepatic cholangiocarcinomas. I think one of the things that we're interested in, I think we had fewer patients in our study with extrahepatic cholangiocarcinoma. So we only had 3 patients with extrahepatic cholangiocarcinoma, and we had 1 response. And with intrahepatic cholangiocarcinoma, we had 9 patients, and we had 3 responses. So for 009, so 3 out of 9 for intrahepatic, 1 out of 3 for extrahepatic. For 009, it was identical. And so that is also something that makes us excited, that this drug could be broadly applicable to the various types of biliary tract cancer. So 009 was identical in patients with intra versus extrahepatic cholangiocarcinoma.
Okay. If you had 2 separate courses of the same chemo, would that exclude you?
Probably, yeah, that's probably okay. That's
Okay.
probably okay. But we would take that on the treating doctor would take that on a case-by-case basis.
Okay. Do you expect the study to eventually be open to those patients who have received 2 lines or more chemotherapy?
Eventually, we will do that, yes. That would be in a different study.
Okay. So chemo plus radiation would exclude me from the study?
No.
No. Okay. So what about targeted therapies? Does that count as a treatment, correct?
Right, it does. So that's one of the things that the FDA was very specific with us about, that, for folks who have an FGFR2 mutation or an IDH1 mutation, now we're learning about others, at the Cholangiocarcinoma Foundation meeting, right? There are now others, and FDA was pretty clear with us, if a patient has one of those, they should get that drug. And I would say the same thing that I just said about, patients who've had 2 therapies, right? So I think another study that we're working on would be for a study for patients who got a targeted therapy. So if you got gemcitabine cisplatin plus or minus Imfinzi, followed by Pemazyre, we would want to have a study of 009 for those patients. And that's something that we're also working on right now, but that's not part of this study today.
Okay. How or when can this be used with interventional radiology, such as to fortify a hepatic artery embolization?
Sure. That's a fascinating question. I've never been asked that one before, actually. I will talk to I'll talk the one set of investigators that we're working with on a combination study for first line treatment. I'll talk to them about that. I've never been asked that question before. I'm gonna write that one down.
Okay. We'll send you a copy of the questions.
Oh, great.
Okay. Yes, this will be recorded and available to watch again, and it will be up on our YouTube channel probably within 24 hours. I've got a few more over here. Is the new study only available with Taxol combination, or do we continue our current chemotherapy regarding FOLFOX? Not sure what.
So it's only available with Taxol.
Okay. We answered that question. This one I think is a no. What about chemo and radiation and then cisplatin, gemcitabine, and Imfinzi? That still counts as 2.
Probably. Okay. But that's also something we would take on a case-by-case basis.
So what about adjuvant or neoadjuvant treatment and then surgery and then a recurrence down the road or something?
That's okay.
Okay.
So neoadjuvant followed by surgery or adjuvant following surgery are both okay.
Okay. So they could do that and then still be put on Gemcis or Durvalumab and then still qualify?
Yes.
Okay, perfect. Is there a time frame from that? Like I've seen on different protocols,
6 months.
6 months? Yeah, okay.
Yep.
Perfect. If patients have brain mets, are they excluded?
No, not automatically, no.
Good, glad to hear that. Possible timeline on the study for 2 or more treatments?
That's probably not this year also, I'm sorry to say. So that the So the third line study and a first line study would more likely be next year.
Okay. So if we hurry and get this accrued, then we can move on to those ones sooner.
I'm glad you said that, Melinda. Yes, no, I think no, but you're making a very important point, right?
Okay.
That it's super important to get this study accrued, figure
Answer
out
the question, and
figure out if it works, and then go to the FDA and talk about the next studies, talk about getting the drug approved. And so yes, the faster we get this study done, the sooner we'll get those next studies going.
Yes. So if we can talk just a little bit more about the crossover,
sure,
what that will look like. So once they progress, they can immediately be crossed over to the experimental drug arm. And
yes.
What does that look like time-wise from the time they?
So we have scans in the study that are every 8 weeks. So that would be 7 weeks of Taxol. And then the way we have it set up is that you can go to the crossover with on schedule for what would be your next dose of Taxol. So it would be an absolute maximum of like 8 or 9 weeks if you get randomized to Taxol before you would, go to the experimental drug.
Okay. What is the process for getting into the study?
So the process would be to see one of the investigators at one of the clinical trial sites where the study is open. So I had the map in the slide that I presented, but you can also see the sites that are open and seeing patients on the clinicaltrials.gov page. And I think there's contact information for the most part on, for all of those sites. So getting to one of those sites is the most efficient way to get into the study.
And if you guys need help, please feel free to reach out to us at the foundation at advocacy@curecc.org, and we'll help you find the right sites and the contact information.
And you at CCF or anybody listening, you can also contact us, and we can help facilitate that as well. And Melinda, if you all get queries, feel free to just contact us directly.
Perfect, we can do that. And I think we will get this updated on our website too, so the trial will be listed there as well.
Great.
Okay, so can you clarify the 6-month break from current first-line chemo to starting this study? I think she's talking about the neoadjuvant.
Adjuvant, right. Yeah. So it's a complicated question, right? So if a patient has surgery and they get adjuvant therapy, and then if unfortunately a patient relapses, depending on what chemotherapy they had for their adjuvant therapy, and if they relapse within 6 months, they could go straight onto the study. Or after the adjuvant therapy, if they got gemcitabine and cisplatin, the regular chemotherapy, and then that didn't work, then they could come into the study.
Okay. So this one is just clarifying. She thought she was excluded, but not after another response. So she's asking again, if she had Gemcis plus a biologic, then changed to Gemcis Abraxane, would she be excluded?
Say this again. I had Gemcis and
Plus,
a biologic, then changed to Gemcis. So it depends why. So if the tumor got bigger on Gemcis devminostat, then was changed to gemcisabraxane, so that would not be eligible because that would count as 2.
Okay, she said the tumor was stable on both, so it would still count as 2.
The tumor was stable on both. Okay. That would be something for the investigator to take a look at. So that's
Like guys say, always ask, right?
Always ask. Yes, always ask. So that would be something to be determined by the investigator.
Okay. Any centers outside of the US taking part in this study?
Not as of today.
Plans for it?
Maybe. It depends. Maybe.
Okay. Sounds good. That was all of the questions that I thought. Oh, one more. Let's just see what that one is. So a relapse has to happen within 6 months of stopping chemo to qualify.
No, sorry. No. So this is, I apologize. We got a little confused with the adjuvant discussion, so I'm sorry about that. So if a patient relapses, which means they didn't have any disease, but then it came back and they got chemotherapy, you don't have to relapse again, right? If your tumor just gets bigger on gemcitabine and cisplatin, you're eligible right away. So, we would, our imagination is that, if the tumor gets larger while receiving gemcitabine and cisplatin, there's as little time as possible between that occurring and starting on the study. So the relapsing was referring to adjuvant therapy. And again, I would echo what Melinda said. Always ask, right? When you get to the investigator, always ask.
Yeah, and I guess I would just explain it. Any treatment given with surgery doesn't count towards an exclusion towards this, as long as there's been 6 months between the last treatment and
that's right. So a perioperative chemotherapy, either before or after, is different.
Okay, different than the relapse. Got it. That can be confusing, but again,
yeah,
always
sorry about
give
that.
the investigators a call and ask them, and it's always worth the phone call to find out. All right, I think we got it. Thank you everyone for joining us, and thank you, Dr. Schuetz, for presenting again. We will get this recording posted on our website, so feel free to look for it if you would like to watch it again. And if you have any questions, you can reach out to Compass Therapeutics, or you can reach out to us at the foundation and we'll get the answers for you.
Thanks so much, everybody. Good luck.
Thank you. Have a wonderful day.
Thank you. Bye-bye.